I'm going to speak about the proximal femoral focal deficiency. I want to remind everybody by the 16th International Deformity Correction Conference. المؤتمر الدولي لإصلاح التشوهات هيتعمل فيرتشوال 7 8 9 أكتوبر اللي جاي إن شاء الله من 7 مساء ل 11 مساء 3 أيام ورا بعض. احنا عندنا 30 جيست سبيكر من بره. عندنا بيتر ستيفنز من أمريكا وروز بروخ من أمريكا، ستيوارت جرين هو الأوثر الكو أوثر مع إليزاروف في كتاب إليزاروف الوحيد اللي موجود، وهيحكي خبرته مع إليزاروف في المحاضرة الافتتاحية لمدة نص ساعة. بيتر ستيفنز افتكروا كلكم عارفينه، وده مخترع الايت بليت. روز بروخ الأمريكي طبعا من أشهر الناس بالذات في الانتراميدالري لينثنينج. عندنا من كوريا هيري سونج طبعا هيتكلم على المانجمنت بتاع السكليتال ديسبليزيا، وتايمون جو من كوريا. عندنا طبعا تيدي سلونج، بروفيسور تيدي سلونج من سويسرا المشهور في الاي او والبروكسيمال فيمورال ديفورميتي. بروفيسور هيمن شارما من انجلترا اللي بيعمل هال ديفورميتي كورس. عندنا بيتر كالدر من انجلترا. جيمس فرناندز طبعا من شيفيلد، جيمس فرناندز كلنا عارفينه. كيفن تيتسورث من استراليا. فرناندو دولهرتا من مكسيكو برضو. وعندنا ماريتس لوبتشر فروم ساوث افريكا. كتير الحقيقه، مش هقول لكم كله لان الاسماء كتيره. ارجو كلكم سرعه الاشتراك في الجمعيه ان شاء الله، لان المؤتمر ده الحقيقه فيه موضوعات كتيره جدا وحاجات كتيره جدا تهم معظم الناس اللي شغالين في الديفولت. دي صوره من البيبرز، اول بيبر عملتها من 27 سنه منشوره في البيدياتريك اورثوبيدكس. عملتها مع فرانز جريل، بافل دونجل، وشتاينفندر على الكونجنتال شورت فيمر. كانت على حاجه و50 عيان من الكونجنتال شورت فيمر. فيها برنسبلز كتير الحقيقه ما اتغيرتش، وحاجات كتيره اتغيرت تفكيري فيها لغايه ما عملت كلاسيفيكيشن هوريها لكم دلوقتي ان شاء الله. الانسنس الحقيقه رير. الانسنس الفيري رير اللي احنا شايفينه هو ده اللي خلى الكلاسيفيكيشنز غريبه. عدد الحالات اللي بتبقى موجوده في اوروبا وامريكا محدوده جدا، فتلاقيهم تابعوا الحالات لمده حاجه و20 سنه، عدد محدود جدا، وهتلاقي الكلاسيفيكيشنز بتاعتهم بيزد على قاعده محدوده من الحالات. لدرجه ان شفت بيبر الحقيقه كنت هحطها بس ما فيش داعي. واحد عمل كيس ريبورت حالتين منهم الحقيقه ما عملهمش حاجه خالص، هو مجرد عرض حالتين كونجنتال شورت فيمر، وكاتب ان هو عرضهم لان جاله في 6 اشهر حالتين، واكتفى ان ده سبب كافي جدا في اوروبا ان كله في 6 اشهر حالتين ان يتعرضوا فقط لا غير، من غير ما يعمل لهم حاجه خالص. وده يعبر لك عن الراريتي بتاعت الحالات والباك جراوند بتاعت الكلاسيفيكيشنز اللي هي بتيجي. 2/3 of the patients have fibrillar hemilia. I'm going to speak about the classification. Most of the classifications are unreliable, and because unreliable, many unclassified cases. هوريكم الكلاسيفيكيشن the classification I made recently, because it contains many unclassified patients in the current classifications. The most famous classification is Aitken classification. Aitken classification still light now معظم الناس بتستخدمها. هي group A, B, C and D. Group A and B you have a head of the femur. B and C and D you don't have a head. So group A, the femoral head is present and you have severe varus deformity. Group B, femoral head present but ossification is delayed with severe varus and pseudarthrosis, the so-called pseudarthrosis. It's not real pseudarthrosis. C, the femoral head is not present, severe dysplasia of the acetabulum, severe shortening of the femur. D, femoral head is not there, severe dysplasia and severe shortening of the femur. And this is in details. We don't want the details. Papas classification. We were using Papas classification in our paper 27 years ago. And you have class 1, you don't have a femur. Class 2, you have a distal femur. 4, you have the so-called no connection here. Actually, there is always a correct connection. Type 2 have a pseudarthrosis. And type 5, type 8, you have almost a normal short femur. A clinical picture, like many other congenital longitudinal transverse extremity deficiency, proximal femoral focal deficiency include a broad spectrum of defects. Mild deformity results in minor hypoplasia of the femur, whereas severe involvement may result in complete agenesis of the femur. And this is the real clinical picture. External rotation, bulky femur. Almost you have an external rotation. The cause of the external rotation of the whole extremity is retroversion of the femoral neck, and you have to take care of this. If you want to correct the femur, you have to care that you have a retroversion of the neck. So you always have a hip and knee deformities. And this is my classification. We have 4 classified patients. Number 1, morphological abnormalities of the whole femur. You have a whole femur, but you have severe morphological abnormalities. Type 2, you have a congenital absence. A, you have total absence. There is no femur at all. Type B, you have partial absence of the proximal femur. Type 3, you have abnormal proximal femur. Apparent neck pseudarthrosis. It's not pseudarthrosis. It's not. Type B, you have coxavara. Type 4, you have a short femur. So my classification, you have 4 types. Okay? And I will explain each type. You have number 1, morphological abnormalities of the whole femur. Type 2, congenital absence. Type A, total absence, no femur at all. Type B, partial absence of the proximal femur. Type 3, you have abnormal proximal femur. A, abnormal or apparent neck pseudarthrosis. You have coxavara, and type 4, you have a short femur. We have 2 problems. Hip dysplasia and knee instability. It's not related to the severity of the deformity. So we don't include them in the classification. In our experience, you know, we had at least per outpatient clinic 2 patients with congenital pseudarthrosis, with proximal femoral focal deficiency. We didn't find any relationship between hip dysplasia and knee instability and the severity of the problem or any other classification. So we don't them or put them. For each case, we have to examine for the hip dysplasia and knee instability. This is very important point in this classification. And if we have a hip dysplasia, we have to deal with hip dysplasia. If you have knee instability, you have to deal with the knee instability. So type 1, we have morphological abnormalities of the whole femur. So as you see in this type, this is a small short femur, but the femur is 90 degrees inflection. 90 degrees. So look to the picture, it looks like the patient has a CT to measure the femoral anteversion. This is not true. This is a normal plain X-ray of such a patient. This is type 1. Again, this is type 1. You see this, both femurs. Severe morphological change on both types. All these patients are not classified. They are ignored. Not classified. So you don't have these patients. So type 1, you have morphological abnormalities of the femur. Usually with such patients, you don't have a problem. And the patient can move and function. I don't need a treatment of type 1. Type 2, congenital absence. Type A, you have total absence. Type B, you have partial absence of the proximal femur. This is total absence. This is unilateral total absence. If you have a unilateral total absence, the tibia will take the shape of the femur. This is not the head of the femur. This is the medial tibial plateau. This is unilateral. In bilateral cases, you see again, the upper tibia will try to take the shape of the femur. This is total absence. Again, you don't need a treat. In such a case, we treated the equinus deformity, but we don't treat these patients because you have a wandering acetabulum, and just we keep the symmetry between both types. So if you have total absence, like this case again, another is total absence of the femur, it's bilateral. Normally you don't have a functional problem. Partial absence. We don't have the proximal femur at all. There is no proximal. We have only the distal femur. And the treatment in such a case is pelvic support osteotomy for this part, and we do tibial lengthening. We do over lengthening of the tibia. And we published that before in this paper 27 years ago, that we can do over lengthening of the tibia, and we are not going to have both knees at the same line, but at the same level, transverse level, but it does not cause any problem to the patient. And look here, in this bilateral case, this hip is type 2A and this hip is type 2B. So both hips are type 2. And I will show you this example. In many cases, both hips are the same type, but different. This is type A and this is type B. So this is type 2A, no hip. This is type 2B, we have only distal femur. Type 3, we have abnormal proximal femur. Abnormal proximal femur. How abnormal? You see, there is no continuity between the head and the proximal femur. This is not true. There is fibrocartilaginous tissue here which is not apparent. And the people usually describe it as pseudarthrosis, or there is no bone or inside. This is not true. Both of them are the same pathology, such a case and such a case. Or we have coxavara, clear coxavara, as you see here in this patient and that patient. Coxavara. So abnormal proximal femur. Again, I don't talk about the dysplastic acetabulum. You see here, there's the dysplastic acetabulum on both sides, but here there is no dysplastic acetabulum. So dysplastic acetabulum is not related to the type of the deformity. So I didn't include it. Type 4, you have almost a normal femur. You see a normal femur, short femur. And this patient needs only femoral lengthening, nothing more. So now I made you I classified the congenital short femur or proximal femoral deficiency into 4 types. And I described the treatment of each type, and I will show you some examples. And this is type 3. Apparent neck pseudarthrosis and coxavara. And this is a bilateral case, type 3. Type 3A, you have apparent neck pseudarthrosis. It looks like a pseudarthrosis. And type B, you have coxavara. But both are type 3 in my classification. And another surgeon, not myself, just treated the coxavara, and I'm again against treating this coxavara in such a patient, but I didn't do this patient because he has hip dysplasia. And you have a hip dysplasia, and you want to treat the coxavara, take care of the subluxation. Anyhow, he left the patient with the so-called pseudarthrosis, or abnormal proximal femur. And this is about perhaps 160-degree angulation, which makes the femur bulky and very small. And this is 3D to show you the deformity. It looks like 2 separate pieces of bone with nothing in between, which is not true, as I've told you. What we do for such a patient? We do distraction, histeogenesis for this apparent pseudarthrosis. This is apparent and not true pseudarthrosis. We fix this fragment, as you see here, and we fix the acetabulum, and we keep those together. Then we fix the distal femur, and we do distraction. You see, we do distraction in between. So we correct the angulation with distraction. So we apply distraction histogenesis for the so-called or the apparent pseudarthrosis. As you see, bone started to form. The distraction stimulates the interface, which is usually fibrocartilaginous, to correct the deformity and to stimulate bone formation. You see here, the bone formation, the bone formation. This is close treatment. We don't do super operations at all. We do only simple operations. You know, we are less than average surgeons, so we don't do super operations. This is just a conservative treatment. This is the bloodless technique. We didn't do any incision for the patient. You see, finally, we have very good bone formation and some sort of lengthening too. Correction of the deformity, gradual correction. And we have severe infection, so we removed this half pin. And this is after removal, you see the picture. And now, after 3.5 years, and you see this picture at the beginning, you see the angulation, and now the picture, after 3.5 years. Remember, this was almost 160 degrees angulation. What's the management afterwards? We are going to do pelvic support osteotomy here and lengthening of the tibia. Another example of abnormal proximal femoral. This is the most difficult part to treat. So I'm going to give you some examples with the simple operations. Again, this patient was looking like absent head and absent proximal femur. With follow-up, you see this is the head and no bone here, but there is an important tissue here. This is not non-union. You see, with developing walking, and the patient started to have progressive upward migration. See, progressive upward. Again, we applied distraction here. Distraction stimulates the bone formation in this segment. You see, they started to have bone formation after removal. You see the bone forming. You see the bone formation. See the bone formation. Then we put valgus plate. We use the valgus plate developed by Tedis Longo. They are important to correct the varus deformity as a preliminary step to lengthening. You see here. The hip is okay. Before lengthening, we are going again to have a CT with reconstruction for the hip before doing lengthening. Again, we don't include the hip dysplasia into the classification. Why? Again, there is no relationship between the severity of the deformity and the hip dysplasia or the knee problem. Another example of the abnormal proximal femur with apparent neck pseudarthrosis, as you see here. Again, we just used the valgus plate. Look to the acetabulum. With the severe type, it's almost good acetabulum, very good acetabulum. We don't have to do anything. Complete union. Then we removed the plate and we did femoral and tibial lengthening at the same stage because we have severe shortening. We did osteotomy, both corticotomy of the femur, corticotomy of the tibia, and lengthening of both of them. We removed the femoral frame first. You see again, this is to show you that the hip is okay. And we did lengthening both. Again, he's going to need more after 3 years. In conclusion, my classification of congenital short femur or proximal femoral focal deficiency into 4 types. Number 1, type 1, you have morphological abnormalities of the whole femur. And you don't have to do anything because in such cases, you have very good function. The patient can run, can do everything. We all have video clips to show you the way the patient moves, but we are in shortage of time. Type 2, we have congenital absence. You have total absence. Usually we don't have to do anything, just bracing the patient. Partial or proximal femur, you can do pelvic support osteotomy and you can do tibial lengthening together. Abnormal short femur, proximal femur. If you have apparent neck pseudarthrosis, you can do distraction histeogenesis and you do then femoral and tibial lengthening. Cook-Savara, you can do lengthening. You have short femur, you can do femoral lengthening directly. Again, for each case, we have to examine for hip dysplasia and knee instability. There is no relationship at all between the severity of the deformity or the type of the lesion or the type of the proximal fusion and the lesion. Thank you.